So I have no further questions for Dr. Winter, but I think you have a couple of matters that you want to ask him about.
Just a handful of questions, if I may. Can I begin with the article from the Lancet? You read the Lancet. You read the Lancet at the time.
The Lancet is a must-read, yeah.
And so on the 1st of September 1984, now the importance of that might be the date. Your memory is that your tests conducted by the Middlesex came back to Thanet sometime the end of October, beginning November. Is that about right?
Yes, for certain. See, on this list of authors is Dr. Tedder from the Middlesex. He was the virologist, and it was his test that was made available to the haemophilia directors. And it's my recollection, which fits with this. This is the very early evaluation of actually two tests.
Yes.
You read, and I can't remember which one we were offered or which Dr. Tedder did. But anyway, it was very, very short, very early October that we got the news that the test was available. And then, as we've discussed, it's a few weeks later that the process is finished.
The authorship, if we just look at the top of it, there's Rashani Chansong Popov is put as the first author, but then we have, was it Professor Weiss or Weiss? I don't know if you've come across his name before, but he as I understand it, on behalf of the Chester Beatty Laboratory, was developing the test which was proposed by him and by Tedder as a test to be rolled out across the country. And I think the inquiry may hear later from various documents that the proposal was made perhaps in July, certainly in August. And by August there was a test. And it was this test which, from what you're saying, was used for your patients in due course. Now, and it's a fairly impressive list of authors, isn't it? It includes Pinching from St Mary's, Krask from the Public Health Laboratory, and Dr. Barbara from the North London Transfusion Service.
Yes, there aren't any haemophilia doctors, but they're just one of the subgroup of patients. But this is a distinguished list of HIV specialists. Ian Weller was head of the group eventually at the Westminster, I think, and the Middlesex. And Tony Pinching was obviously a leading light with Weber of the very large St Mary's HIV treatment centre.
So, if I can just draw one or two aspects of it to your attention, and then ask some questions about it. If one looks at the summary, left-hand column, the very bottom, Henry, the results were that testing those who were haemophiliacs, doesn't tell you here how many there were, 34%.
There were 184 on
Yes.
one of the tables. Yeah.
I was going to take you to that, but you've answered that question. So 34%, that's 68 out of 184 haemophiliacs receiving pooled clotting factors tested positive. So roughly a third, very nearly a third, which, as far as this cohort was concerned, was rather less than you recollect. In due course, it was reported to you that Professor Kernoff's research had found in the Royal Free.
Well, the interest of this paper is this is just immediately before the haemophilia directors are about to test and find that 80 to 90% of regularly treated patients are HIV positive. So, against the context of Professor Bloom's remarks, this isn't going to be a big problem. This might perhaps be an indication that the percentage of people affected is much greater than we had anticipated. I mean, it's surprising the figure's only 34%, but I just make the comment, looking at the patients they've got, patients were drawn from the Middlesex, Mary's and St Stephen's. St Stephen's actually isn't a haemophilia centre at all. The other two are small centres, and we're just told they'd had factor 8, including commercial. So that really, to me, I'd like to know a lot more about those patients. They may not have been very heavily treated, very regularly treated.
I think it says they were regular recipients. I think that's in the methods.
It does say regular clotting factor replacement therapy.
So that would suggest that they were not necessarily mild or moderate.
But my main comment is one is surprised that the percentage of positive people was not greater than 34%, given the results that are about to emerge the next month using the same test.
Might it be that the picture varied across the country?
Well, that wasn't a feature. I think wherever you were looking in England, you found that all the major centres had very similar levels of incidence of HIV positivity.
Well, I think we'll have a look at that in the inquiry and just see what they were reporting. But thank you for that. The next part I wanted to ask you about was, given that this said a third of all haemophiliacs receiving regular clotting factors, commercial clotting factors, appear to have seropositivity. And this is in the Lancet, which is required reading for most, if not all, doctors. What was the reaction to it in the haemophilia doctors community?
See, I think if we were testing beginning of October, I think we had already been told about this test and that it was going to be come to us, because we'd have had to line up the patients and write to them. And if I was testing October, I must have written to them earlier than that. So I'm thinking that we already knew about what this survey had shown and that we had already been informed that the test was coming our way. So our attitude was, Dr. Tedder, who we knew, has got this test. We're about to be able to do it. Here's a preliminary report indicating the antibody positivity, and all the more reason for us to do our tests. But it's rather slipped under the radar, this paper, because we've jumped from Professor Bloom and the theories of this isn't going to be a problem to our 80 to 90%. This is a bit of a middle ground one, which I think has rather got hidden.
The introduction on the right-hand column, just the very beginning of that, if you please, Henry, if you can highlight that. The likelihood of the acquired immunodeficiency syndrome, AIDS, being caused by an infectious agent has been apparent for some years. Well, that's what the virologists appear to be saying. The exponential rise in the number of cases of this disease has been restricted to certain well-defined risk groups in a pattern that strongly suggests an agent transmissible by sexual or blood contact. I think you would, from what you've said, that you would agree that that's a fair summary.
Well, it was. I wouldn't have used a phrase like for some years, but you'd certainly, as I've previously given evidence, by the time you've got the haemophiliacs in the summer of 82 in the US, the San Francisco baby at the end of 82, you'd have to, in my view, strongly suspect. So I think I might have written, the likelihood of it being caused by an infectious agent has been apparent since at least December 1982, which was less than 2 years after the paper was actually published. But it's a fair point.
Then it says case clustering supports this hypothesis, so that would be an epidemiological construct, would it?
That would be in relationship to the sexual contact.
I see. So, if you like, further support for that hypothesis, yes. If one needed one now, because by now, in September 84, it is generally accepted, I think, that the cause was a virus, and generally accepted it was to be known as HTLV3 or, for that matter, LAV.
Yes, HTLV3 was the initial terminology at that stage.
And I think the only other thing I need to ask you about, page 480, it's the fourth page in, Henry, if you please. That's the page, and the second paragraph beginning the high prevalence of. Says there's the high prevalence of HTLV3 antibodies in haemophiliacs found in this and other studies, and it sets those out below. I think it cites just one at footnote 12. It's probably a Danish study, Melby and others. Has to be set against the relatively low incidence of disease in this risk group so far. So the prevalence of HDLV3 antibodies set against the relatively low incidence. And this high antibody prevalence also shows the retrovirus or its antigen is present in pooled blood products, especially factor VIII concentrates. Then that the likelihood that infection resulted from commercial rather than National Health Service factor VIII concentrates is increased by our failure to detect HTLV3 antibody in over 1,000 blood donors from the North London Blood Transfusion Centre. This finding is also reassuring as to the low risk at present of acquiring HTLV3 infection or AIDS by blood transfusion in Britain.
So this is very important reaffirmation of my point about if Dr. Owen's initiative had been successful, these are the sort of donors who would have been giving blood turned into factor VIII in Britain. And in the 1,000 donors, there's no HIV in it. So, we would have moved from a high-risk population of donors with HIV to a low incidence of HIV, and that might have made a difference.
Well, yes, I see that entirely, and I thought it would support what you have been saying to us throughout. If I may say, taking a general view, asking something rather more general than specific to this article now, if I may, what you've described as a healthcare crisis and a treatment disaster in the course of your evidence, you've given me the impression that it is something which has caused, at the time and since, deep concern to you that it should have happened at all.
Well, of course. I mean, here's a disease, haemophilia, which is pretty unpleasant and lifelong. And my take on the whole thing over a long period of years is that decisions were made in the mid-1970s that were clearly at the time wrong, and that other countries looked at the same situation and made the correct decision, which was it is not sensible in terms of safety of patients to be using clotting factors that have come from paid blood donors in the US. No doctor would have signed up to that idea in the mid-1970s. So those decisions are unfathomable, really, to a clinician. How could have a body looked at the evidence and said, that's a perfectly sensible thing to continue to do? So as a result of that decision, 1,500 people died.
So if I were to ask, what do you see as, amongst the various different contributory causes for different parts of what we have been discussing, what you would see as the single most important cause, either by taking action or failing to take action,
yes,
would that be it?
If you were only allowed to have one witness for this inquiry, it would have been David Owen, because everything revolves around that moment in time. I've already given evidence that I don't think the hepatitis epidemic could have been affected by becoming self-sufficient. But Dr. Owen was so close. He even had a press conference to announce self-sufficiency. We were so close in getting to be where Scotland was, in being effectively more or less self-sufficient. If that had happened, given all that we'd then learnt about the incidence of HIV in American plasma compared to British plasma, this is retrospective speculation, always dangerous in medicine, but I have always thought hepatitis could not have been changed by and large, but it had always been a matter of great concern, given all the people who lost their lives. Would it have made a difference if David Owen had not become Foreign Secretary and stayed for another year and got it through, as I'm sure he would have done?
For some of the, amongst the perhaps then lesser causes, you have identified a structural problem, if I can call it that, in the way in which advice was given rather than direction. That you wanted to know what to do and no one would tell you except it was your decision. Was that effect? How would you have wanted the system to work? It goes back to your discussion of clinical freedom, which you described when you first mentioned it yesterday as dangerous.
Well, I've already expressed a view that in retrospect I think the UK HCDO, faced with a mix of opinions, issued guidelines to doctors that were too flexible. They should have been firmer, should have said, we think you should do the following. This is a very complex moment in time, but this is our best advice. We think you should do the following. There should never have been phrases like, but every clinician must make up their own mind, because that was an invitation to flexibility and an invitation for doctors to carry on doing what they wanted, which was a whole variety of different things. So I think it was well-intentioned, but unfortunate. As you will gather, I would very much like to have seen the Department of Health having a much stronger, more overt role in the whole crisis, which was apparent, and working together with UK HCDO to take matters forward. And I would have also liked to have seen Elstree and the transfusion services be much more politically active and doing much more, frankly, to improve the provision of clotting factor concentrates for people with haemophilia in this country. I think their activities were also a relevant part of what happened.
So you would have wanted the department to have been more proactive.
Yes.
In what ways in particular?
Well, I think they could, as I've said, they had a nominated doctor who attended our meetings. It would have been all too easy for this doctor to say to UK CHDO, this is a serious healthcare problem. We should work together. I would like a senior figure in the DHSS to be issuing this guidance to doctors to make it more formal, rather than a UK HCDO, as Dr. Savage always said, was an informal gathering of haemophilia doctors with no constitution. We just all got together and did what we thought was best. We didn't have a constitution. If the DHSS had issued advice, that would have made it of more stature. And I think that could have been very helpful. And to be honest, they could have had a wider group looking at all aspects of the crisis. Are we doing everything that we possibly can to improve the production of clotting factor concentrates in this country? Is it happening fast enough? Is the funding sufficient? Is the staffing sufficient? What is getting in the way of this country producing more concentrate and stopping us having to import concentrates from America made from the sort of human beings we saw in the World in Action documentary?
I think it's probably allied to that. But let me introduce the question in this way, that those who listened to Council's presentation about Dr. Bloom and the Cardiff Centre may have been struck by the number of different committees relating to the healthcare crisis, as you've described it, upon which Professor Bloom found himself sitting, all of which seemed to be discussing similar aspects of the same problem. Perhaps that may be a comment which may be wrong, but that I can be addressed about that in due course. And perhaps not always speaking with entirely the same voice. Did that represent your view of what was happening at the time?
Not particularly. I think a lot of these others committee were sort of virological, and we were rather remote from that. But you'll gather what I would have liked, if you like, as a sort of SAGE. You know, we have SAGE now. We would have liked a haemophilia SAGE. Let's get all the interested parties in, bang everything together, and sort it out. Instead of which, as you're implying, there was sort of an individual, you know, one agency was doing something, another agency was doing something else. This was a serious enough healthcare problem for us to want a much more coordinated approach. It should have been the DHSS leading that, I think.
So some authoritative body speaking directly to government.
Yes, exactly.
Or through government.
Exactly.
I see. The next, and it's the last thing I think I want to ask you about, is in respect of your particular, you're in a particularly good position to deal with this, because you are, in your, you're thinking, the only, or one of the only, doctors who combined haemophilia treatment with HIV treatment. Do you think that's been an advantage to your treatment of those with haemophilia who had HIV?
Well, I'd like to think so. I mean, I think it worked out well that I was able to look after their haemophilia and their HIV. Quite a lot of patients, I've described already, they would ring up the centre and be told, many patients were going to different hospitals. Some of them not even in the same town. So they were at a haemophilia centre X, they went for their HIV care to another centre or hospital Y, and they went to a third place, Z, for their hepatitis care. So they were all over the place. And I think it was, I hope it, you know, my patients felt it was good that at least they had the haemophilia and the HIV under one centre, and the only thing they had to move sideways to in the same hospital was for the hepatitis consultant, you know, in the outpatient clinic just round the corner. So it was all centralised. I hope they found that helpful.
Was there a reason you didn't do combined clinics?
I think they now happen now. Eventually I was replaced as an HIV physician when the work got too much. And I did then start to do combined clinics with this new HIV physician on HIV. I think the number of people being referred to Dr. Muller, my hepatology colleague, was not enough and not regular and frequent enough to warrant regular clinics. But he was terribly helpful, and he saw the patients very quickly and dealt with them very promptly and communicated. So that was fine.
So going back to the problem for the individual who is suffering from the condition of haemophilia, first of all, but the troubles that come with HIV infection and possibly with AIDS, and the problems which come with infection with hepatitis. They might also have needs for physiotherapy or needs for counselling. It might be thought that it would be of advantage to them, ill as they are, to have that all in one place. Would you agree with that, or think that would have been difficult to organise?
Well, that would have been ideal, and that's what we had a physiotherapist in our centre, and we had a counsellor in our centre. So we ticked all those boxes apart from the hepatitis one. All I've been trying to do is just to make the point that this sense of rejection that was spoken about was sort of reinforced by not only can I not go to the centre that gave me the treatment, that gave me the infection, I've actually got to travel to a different hospital for my HIV and another hospital to hepatitis and a GP. I've got 4 sets of doctors in 4 different places. And for someone who's not very well, that's far from ideal.
Yes. Well, that's all that I wanted to ask you myself. Ms. Richards?
No further questions from me, but Dr. Winter, is there anything else that you would like to add that we haven't covered?
I had a long list when I came in yesterday morning, but I'm extremely happy to say we've covered everything.
Good. Then that's it for today, sir.
Well, not quite it, because I would like to say something to you personally, if I may. It's never easy, I think, to give evidence, and particularly when we might have had every right to think that you would have given it in a rather jaded manner, having done it twice before to 2 other inquiries. But you've shown absolutely no sign of that, and I may say that I am very glad that we heard you first of the clinicians, and that you had such a fluent recollection and an astonishingly good memory for dates and events and recollections. But in particular, I'd like to thank you for your frankness. You tell it like it is, I think, from your perspective. And that is really valuable for me. That's as I see it anyway. And given us a valuable insight, a number of valuable insights, into what it felt like to be a haemophilia doctor in this most difficult of times, particularly coming into it, as you did in the start of December 1983, as a consultant, and then having your responsibilities. And I suppose you would have left some of us wondering if they could bottle your secret for getting money out of your local finance director, because that might be very useful to other people.
Yes. I'm still not sure how it worked.
But it didn't seem to work on the DOH.
No, that was a different matter.
Thank you very much.
Pleasure.
And so we reconvene on Tuesday to hear the evidence of Dr. Brian Colvin.
Well, ladies and gentlemen, that's it for this week. Thank you very much for your attendance. I have already thanked Dr. Winter myself. If you were travelling home and going any distance, travel safely. But in any event, stay safe. And those of you who are coming back next week, I look forward to seeing you then. If not, I may see you, I'm sure I will see you later. Thank you.